Hey everyone, thanks for coming back. Thanks for checking us out if this is your first time. I think a lot of you know me, but you don't know who I'm with today. I'm with Dr. Giacomo Fabbri. I'm in Seattle and he is in, tell him where you're at.
I'm in Italy, my friend. How are you?
I am good.
Hello,
I'm good.
everybody.
Hey guys. So yeah, I'm in Seattle. What is it today? Friday morning here, like 9 a.m. And what is it over there in Italy right now?
Now in Italy, we are 6 o'clock in the
Yeah,
afternoon.
yeah. So nice 9 hour difference here, which is pretty sweet.
Yeah. It's dramatic time. Yeah. So different.
I know this is your Friday night and you're here with me. Thanks, man. I appreciate it.
It's my pleasure. It's my pleasure. Absolutely. I know your podcast is fantastic. I follow you, and to have the chance to share with you, my story, my experience in dentistry, it's a great privilege. Thank you so much.
No, this is great for me. Actually, the reason I actually wanted you on was I actually went to two of your lectures before. I saw you at the AO actually when you were in Seattle. I came out of that. I've been practice 18 years, and I came out of that learning new things. And when you come out of a lecture, dinner lecture, whatever it is, learning some new stuff that you want to integrate into your practice, that's a win. Even if it's like one thing, I find it's like super helpful, right? Because little pearls are like game changers in a lot of ways, right? For efficiency in your practice, workflow, actually, it's all depends on the patient and treating them better and giving them better outcomes, I think, right? So if that makes sense to you, it makes, I think that's awesome. So before we get into all that, and today before we get into everything, I wanted to let people know in that lecture that I saw some cool stuff that you were talking about, and a lot of it was first time material that I've listened to. Some of it was like based on hemidesmosomes. It was based on, biologic zone of the implant versus restorative versus this and that, how deep to sink your implants, what happens if you remove an abutment on and off, a temporary abutment on and off multiple times, like why is that a bad thing? Why is that a good thing? All that stuff, I came out of there with learning a lot of new information, and there's a lot of science behind it. So I'm hoping we're going to get to a lot of that today as well. So if you have any questions on aesthetic zone implants, tissue healing, you're having issues with perimucositis, things like that, implants integrating, restorative space issues, I think you'll hopefully get a lot out of today's presentation. It's not even a presentation, we're just chatting really. So before we get into all that, so you're in Italy, I assume you're Italian. Did you wake up like in the third, fourth grade and go, I'm going to be a dentist, one day, how'd you even become a dentist or want to?
Honestly, my desire was to become a doctor. I don't know in which field specifically. And I remember that 1998, maybe, I decided to make my application for dentistry also, and also in medicine. And I was able to pass the applications. And in Italy, it's so challenging, because in each university, every year, only 25 students can start with the school. So I decided to go with that for dentistry, and
Wait,
absolutely
in the whole country, 25?
no, in each university.
Oh, in each
In each
university.
in
Oh,
each
okay.
university. I
Yeah,
mean, in
that's
Italy
still
we have I don't know exactly how many university we have, but
yeah.
it's really few students, so it's not easy to get the possibility to take a part in this program in Italy. So I had the chance to pass the exam, so I say, well, why not? And so I go in this direction, and I have my graduation after 5 years, and I was immediately happy about this kind of the topic of field of interest, because I know I love dentistry because it's something that can combine easily clinical aspect, research, also give you the chance also to gel with your patient. So I think that is an activity that's it's really good. In the recent years, of course, situation is getting worse. Many reasons, after COVID, also patients becomes a little bit more complicated to manage, maybe also from the psychological aspect. I think that everybody in each country has evaluated it.
Right.
But anyway, I'm really happy to work as a dentist here in Italy. I mainly focus on prosto. I'm a prosthodontist, but also I manage lots of implants. And I think that something that makes really the difference in my lecture is related to the fact that I look at the implant and I think to the implant and I look how to improve the quality of my implants, thinking prosthetically. So not just surgical things, not just bone site preparation, not just GBR or how to get volume from connective tissue graft or bone graft, but I'm really focused on the prosthetic workflow and look how the prosthetic workflow can improve.
I've been performing full arch dental implant surgery since 2012. I started back then with Nobel implants and I continue to use them today. Getting consistent results over time and seeing these restorations in function over that length of time has basically strengthened my use of the product. There's over 100 implant systems out there. I just choose the one that's been the most consistent for me.
The short term, but also the long term results.
Being a prosthodontist, and I assume you place implants, right? Obviously, as well, right? So you do surgery, you restore them, you do the whole thing. So you're well versed. And I know there's so many dentists and prosthodontists and even other specialists that may place implants and restore them. It's a lot. In my practice, I just place them. I don't ever restore them unless it's a temporary situation. I don't do anything permanent. So I don't have a lot of experience in that sense of it. But yeah, so you got out, you did pros afterwards as well. And then you got out, you went into private practice. Did you move around different countries? You stay in Italy? Like what happened?
Yeah, after my graduation, I had the chance to add some postgraduate program, also in Gothenburg, in Sweden, but also in Belgium with Dr. Eric Van Doren. But I think that's the master program that really gave me a lot of contribution in my actual career. It was the master program with Dr. Mauro Fradiani in Italy. And this is my mentor probably that was able to give me a lot of passion, a lot of energy in the field of the prosthetic dentistry on natural teeth and of course also implants.
Awesome.
And now of course I mainly work, mainly work in Italy, but I also have a good connection with some university in Italy and also abroad. For example, I have a really good connection with the Stanford University, with the department of Xeal. And this is thanks to her and her department that I had the chance really to evaluate in details, to delve into the details of the soft tissue, of the hemidesmosome, because we made some nice publications together.
Yeah, the hemidesmosomes was legit. That's some of the takeaways I actually got from the lecture that I attended. I forgot about hemidesmosomes. I mean, I was, when you for pathology, like pemphigus vulgaris and all those things, there's desmosomal, hemidesmosomal attachments that we worry about, or not even worry about, but clinically there. But you're talking about implants now, and that we'll get into that, for sure. Yeah. So where did you get most of your surgical training then? Through your multiple fellowship type things after dental school, or was it in dental school?
Yeah, at the dental school, but also after my graduation, I had the possibility to learn a lot from many clinicians from all around the world, making some specific postgraduate program. So I really had the chance to stay really close to really good periodontists, to really good oral surgeons. Yeah. And in that way, I had the chance really to put together all these informations, these different approaches, and combine them with the prosthetic thinking. So right now, everyone right now has his own specific approach, right? Yeah. Everyone, in particular in Italy. In Italy, everybody feels like Michelangelo. So everybody wants to have your own recipe for everything, right. For cavities, for fillings, for veneers, how to cement the veneers, how to make the GBR. I think that's for Italian is something normal, but of course the basics and the right knowledge is always something fundamental, crucial.
True, yeah. I think people like the idea about having their own technique and teaching that and kind of marketing that in a way like this is my thing. And that's fine. Obviously use what works, and there's so many different ways to come to the same outcome. So I don't think that's a bad thing. So that's great. So you started working. I know you do plenty of lecture presentations. You're involved with research and clinical. So you do a lot of things. Yeah. So in the lecture that I attended, you had this one slide. It was like a puzzle piece, and it says, implant success, bone and soft tissue stability. And you kind of go over prosthetic issues and surgical issues that can cause implant issues or problems. And this is like that puzzle piece slide. Do you remember that?
Yeah.
Yes. So here's the thing. So you went over surgical issues when you're placing implants that could be a problem. And one of them is, is the implant well placed, surface design, that sort of thing. Can you kind of go over some of that stuff? I think I get a lot of questions, when I show implants that fail on Instagram or wherever, like, why did that fail? Like, what happened? There's so many questions that come up. It could be a lot of things. And so this slide kind of is a nice little thing, I think, kind of goes over some options. Or the other part of it is when I do a consult for a failed implant that comes in, and then the patient asks me, so what happened? I had this placed 4 years ago. I had this placed 10 years ago. I had this placed last month. So there's different issues there. This one here, you're talking about surgical issues versus prosthetic. And like they said before, the implant placement, surface tension? Like, what is all that about?
Yeah, the point of that slide is to point out with the audience that the success in implant dentistry is not just related to surgical aspect. Today, normally, when you have a failure on implants, normally you think to the surfaces of the implant, you think to the implant design, you think to the implant threads, to the surgical aspects. But of course, success depends on many factors. And in that puzzle, I had to point out how we have 50% of factors that comes from surgical related aspects. And we have the 50% of the other aspect that comes from prosthetically related factors. I mean, stability of the connection, just profile, surfaces of the abutment, treatment of the abutment, many factors. And in that puzzle is also clear how there is one piece of the puzzle that unfortunately we cannot control. I mean, the clinician can control all the surgical aspects, or maybe can try to control all the surgical aspects, can try to control all the prosthetic aspects, but there is one piece of the puzzle that is not easy to control. That is the patient. Patient, it means immune response of the patient, systemic condition, habits, and all these aspects. Because, of course, each patient has his own immune response, his own microbiota. So, of course, it's impossible to standardize everything for each patient. But just to explain how success is not just implant design or surfaces of the implants. It's many multiple factors.
Yeah, so like this slide here, implant placement. Obviously, if the implant is not placed correctly from the start, it's hard. It's hard. That's an obvious issue a lot of times on positioning, x-rays, parts and pieces that don't match up well. You have another one, overheating is part of the puzzle piece. That's a surgical complication. So sometimes so I think most implant systems, obviously all of them, have some sort of rough guideline on drill speed, RPMs, when you're placing them. It's like 800 to 2,000. These are for conventional implants. We're not talking about the other ones that have a completely different protocol. Is there a setting that you like when you're placing conventional type implants? 800 speed, does it matter to you? 1,000 RPM? Those are for conventional implants. We're not talking about the N1 or anything at this point. But
no. Of course, I place really a huge number of implants with the regular drilling protocol. And of course, the overheating of the bone is not really a huge problem. Because today we have the possibility to compensate this issue. But of course, high-speed drilling protocol can cause also a bigger trauma to the bone. So this is the reason why recently a company started to look to different approach in order to preserve much better the bone, to work more gently with the bone, to preserve bone chips. Because of course, when you work in high speed with irrigation, you remove completely the bone chips. If you work in a low speed without irrigation, you can collect the bone chips and maybe you can maintain the bone chips in the osteotomy. And this, of course, is a good thing for the osteoinductive properties that you have in the sides. So, sometimes I think that it's really important in our daily routine to try to get out from our comfortable zone, because if it works, doesn't mean that it's the best, no? So get out from the comfortable zone and look what we can do. And if really we have a benefit looking out of the box,
Yes, overheating I think it's really complex. So if let's just say I'm doing a conventional implant. I'm going at 800 RPMs. My pilot drill, first twist drill, and let's say I'm working in the mandible. It's a little bit more dense bone generally.
Yeah. And maybe in that case, we have to use really brand new drills in order
that's
not
the other
to
thing
avoid it.
Exactly what I was going to get to. So let's say like each drill system that you have, like let's say you get 15 to 20 uses. That's what they say, right? Out of your system.
Yeah.
For most systems, you're using those first couple drills the most. So they're going to get the burned out the most because you're not doing molars on every case, right? So you're going to use that 2.0, 2.3, whatever, the smaller ones the most out of that system. They're going to get burned out the most, right?
Yeah.
And so like things like that, how sharp your drill is, like is this the 10th time you're using this drill on a case or is it the first time? I think there's a big difference we're not really paying attention to.
Absolutely.
That can cause the bone to heat more because now you're using a dull instrument in that way, right? So all these little factors work together to create this overheating effect. Your irrigation's not pointed the right way. It's not getting through your guide. There's so many different ways, that this can affect that from the beginning. So yeah, overheating is multifactorial. There's lots of different ways that can happen. I totally agree with that. Surgical trauma is kind of the similar thing. You know, how well was it placed? Are you taking the implant out of the container and bumping it on something before you put it? Like, you know, little things that did your system touch it? Did your system touch it with a suction accidentally or something contaminate it before it actually even gets to the patient? There's all sorts of little factors in this whole situation, right?
Yeah, absolutely. Also the insertion torque, for example, because the surgical trauma is not just related to the drilling protocol, but is also related to the implant placement. Maybe when you place the implants with a super high torque and the implant has a wrong design, of course, the risk to have a compression at the bone level, in particular in the crestal layer of the bone, is of course a risk.
Right.
And to be honest with you, if I have to think to my complication after implant placement, and I have to think to healing, that weren't really 100% perfect, normally are mainly related to implants where the primary stability was super high. It's difficult for me to have problem when the implant is placed with a primary stability that range from 30 to 50 Newton. But when you go up to 50, 70, 80, or even more, that sometimes unfortunately can happen, but maybe happen because we go with the wrong drilling protocol.
You max out on the torque wrench. You're like, look at this.
Yeah,
you know,
of
and
course.
you're like past the last line on it. And you're thinking you're great.
It's not something that I like to do, honestly. When I'm over 50 Newton, really, I'm not 100% happy about what I do.
Right. You know, I totally get that. That makes a lot of sense. You know, you're like, look at this. This is 80 like on the wrench. I can't, there's not even a line past that, you know? So you're right. Placing the implant, and when you really think about it, if you're really doing that, I think most if you place the implant with the handpiece, a lot of them torque out at a certain level and they stop turning. Then you have to go to the ratchet, the hand, you know, driver, and then really now you're using your hand to tighten it even more. And
maybe backward and forward in order to prepare the sides. So, I mean, it's a trauma.
It is trauma. And also, like, you think about it, if you're putting that much force on turning something, what's happening internally in that implant? Also, is it deforming a little bit? So when the dentist puts their little screw in, is it seated the way it should be? Or is there a little bit more space in there now from what you did?
Exactly. It's another huge topic, you know, and of course, on this topic, I think that it's important to mention then depends on the implant that you are using, because you know that we have premium companies.
Right.
And we don't have also premium companies. So of course, if you have a premium company where the products, the wedging effect, the seating is ideal, maybe you can also go with a really high torque. But if the quality of your components is not really good, is not really high, of course, the risk to compromise the quality and the seating of the components working with the super high torque, it's something that can be considered, of course.
Right. And then as a specialist who I place implants, when I see implants that failed for consultations at various stages, a fair amount of times, you know, I may contact the rep to see, you know, if I have a question on why this failed. A lot of times what comes back is, well, the lab placed a non-Nobel screw or a non-Straumann screw or something. They're using a generic screw, let's say, for something. Does that happen sometimes? I know you're different because you're controlling your whole case generally, right? You're placing and restoring, so you know what you're doing, you know, ordering and stuff.
Yeah.
But for a lot of people, they send out for placement and then they may restore them. And so that's also a thing. Do you see anything like that with non-company screws and parts and pieces that cause failures?
Yeah. It's something that really can happen. It's something that absolutely I don't recommend, because in particular in the recent 10 years, everybody started to work with conical connection implants. The conical connection implants are really, is a fantastic fixture. It's a fantastic tool that can be used really in a really strategic way, achieving fantastic results in many and multiple clinical situations. But what is important to understand is that the system has a high performance, but is really sophisticated. And when a system is sophisticated, require a precise components. You cannot use a conical connection implants that require an ideal seating, an ideal active seating. You cannot use it with not an original screws or not an original abutments. I like to say that, a conical connection implant is like a Formula One. And if you have a Formula One, you want to drive it with all the tools exactly original, no? Probably you don't like to drive a Formula One with not original screws. because you feel that when you are in the straight line and 300 kilometers per hour, if something goes wrong, you can make a catastrophe, right?
Yeah.
So it's the same. It's a really high performance system and require high performance component. Shortcuts are not allowed.
Even the tires, like they burn out so fast. Like, if they're not right.
Even the tires, exactly.
Everything.
Exactly.
Yeah, every part
exactly.
of that.
Because sometimes clinicians think to the old external X. External X is another story. It's really a flat to flat connection. It's not really high performance. It's not sophisticated.
Right.
It's with external X, some shortcuts maybe were allowed. Maybe if a conical connection is the Formula One or Ferrari, external X is a Fiat. Okay. So I mean, with the Fiat is a more simple car. You can accept any kind of compromise. Everything works.
Yeah, it'll get you from A to B, but how fast and how cool are you? I guess too. But yeah, that totally makes sense. I think in a lot of cases too, sometimes the restorative dentist may not even know what the lab put in, or they may not think to say, hey, when you guys order your pieces, make sure they're this and that. And so there's a lot of communication, I think, that can clean all that up. So yeah, those are surgical things. And then so, you had some prosthetic issues that could cause implants to fail.
Yeah.
Connection design, like, can you explain that? I know when I was training, like they had a lot of times, I remember in the early part of my training, they were teaching, hey, you want to put a wide healing cap here. You want to push this out and, make it look good. And that went away. And now people were like, no, it has to be more concave. You're getting even deeper than that in some of your connection designs. Can you explain like concave versus seating it versus, like how do you like treatment plan these cases?
Yeah. It's really an important topic, and I think that this topic can really make the difference to today in the success in implant dentistry. Of course, the big advantages of the conical connection implant combined to platform switching is that this kind of implants can be placed subcrestal. In fact, first of all, the name bone level is not really clear because it seems that you have to place the implant at the level of the bone. But the big advantages of these implants is that it can be placed also under the bone crest. And in this scenario can really make the perfect results, and we can really take advantages from this situation. But of course, if you place the implant deeper, you need the prosthetic component, healing abutment, and of course, emergence profile completely different from what we used 20, 15 years ago when the implant was placed at the level of the crest or maybe even tissue level, no? So with the connection that was above the bone crest. So today it's really important to understand this because when we place the implants subcrestal in the deepest portion of the emergence profile, it's really important to adapt a concave, straight design that have to be really far away and distant from the bone. Because of course the bone always requires a space, a distance from the prosthetic components, because always the bone has to be, need a layer of connective tissue. Never you can see the bone in the mouth of your patient. If you see the bone, it's because or you're doing the surgery or you're looking at necrosis. Otherwise, always the bone require a layer of connective tissue, like a pillow of connective tissue that protects it, right? So if you place your crown, your abutment, and this abutment doesn't have the right distance from the bone, of course, the bone remodel. And if the bone remodel, you have, of course, an osteoclastic reaction, and remodel may be exposing the threads of the implants or involving the bone peaks. So it means that you lost the papilla. So it's fundamental to avoid this remodeling at the bone crest level in order to reinforce the outcome and the long-term results.
And this is all, if we're looking at surgical versus prosthetic again, like that's really controlled a lot of it during the surgery. Like if you're placing the implant at whatever level you choose, and then you got to choose what type of healing cap system if you're using that to use. Like, is it like ultra wide? Is it too short, too tall for that space? And so these are all things that start affecting your implant from the jump, from the start, right?
Absolutely.
Right.
In fact, I'm really disappointed when prosthodontists speak about emergence profile when the implant were already placed. So we plan the emergence profile when we place the implant. So the implant placement should be managed together with the prosthodontist and the surgeons. Does it make sense that the surgeon places the implants just in relation to the bone, and then the prosthodontics has to manage the prosthesis, optimizing the emergence profile? The vertical position of the implant, and of course also the 3D vertical position of the implant, has to be evaluated in relation to the soft tissue. are the soft tissues that guides the surgeons on implant placements, not just in terms of vertical position, but also in terms of 3D position. This is fundamental. This is how implant dentistry is changed in the recent years. And when I see surgeons that plan their implant just looking the CBCT, I mean, just looking the bone without having an idea about where the soft tissue are and where the prosthesis should be placed, for me, it's no sense. Because first, we plan the prosthetics part. In relation to the prosthesis, we evaluate the soft tissue, and then we place the implant. If we have bone, perfect. If we don't have the bone in the right position, we can build the bone. This is my workflow, starting from the from the prosthetic design. And the strategic thing today is that the digital workflow in implant dentistry is really a game changer in combining all these aspects together. Because with digital dentistry today, it's easy to have the perfect communication from the prosthodontics, from the surgeon, and communicate correctly and evaluate correctly how to place the implants, the vertical position, the diameter, and also the abutment. We can select the abutment just in the planning, during the plan.
Yeah, that's a lot. I mean, it's just everything that happens from the beginning in the planning, obviously, that's a lot of it. And then the actual procedure part, for sure. When I was training, the whole thing was biologic width, 3 millimeters, whatever it was. It's more complicated than that, right? Can you explain like what you were talking about in your lecture, like biologic running room, like connective tissue zone, like that stuff is pretty cool actually. So I was hoping you can kind of elaborate on that, and I'll show the pictures of what we're talking about, as we're chatting too.
Yeah, absolutely. It's absolutely something really important. It's something that is related, of course, on specific guidelines that we can get for this information, because the vertical position of the implants depends also on these aspects. The point is that every single time that the implant is placed in the mouth and is connected in the intraoral environment, these implants require a biological width, because otherwise it's impossible to maintain the implant connected in the intraoral environment in a healthy situation. And this biological width considers a connective tissue and a junctional epithelium. That is called also peri-implant epithelium, because Xeal Helms in many papers describe how the peri-implant epithelium is really different from the junctional epithelium that we have around teeth. So this space has an height, needs an height that it's more than 3 millimeters. We know that today everybody knows that the implant should be placed 3 millimeter apical, respect the free gingival margin on the buccal side, respect the zenith. But my personal opinion, for me, this information is not actual anymore. Today, with the new solutions, is recommended to go deeper and to keep this space about 4 millimeters, and even 5 in the static area when we work with an immediate implant placement. Because when we work an immediate implant placement, the implants really often is slightly palatal. So if you want to keep a good emergence profile, maintaining the implant palatal, of course we have to go deeper, because otherwise we have a too flat design with our crown. So the problem today, I think that every single time that I have a problem with my emergence profile and with my dental technician, is because the implant is placed too superficial, too shallow, not because the implant is too deep. When the implant is too deep, we have today the solutions to manage it. It's just a matter to understand how to manage it. Because of course, if you have the implant that is placed 5 millimeter deep from the free gingival margin, and you go 5 millimeter with acrylic or composite, or with material that are not completely biocompatible, of course you can have inflammation. But if you manage the deepest area of that running room that is called biological room, with material like titanium or zirconia, completely sterilized, maybe working with one abutment one time, absolutely the scenario change. Composite and acrylic, of course, has to be used like IMAX, lithium disilicate, feldspathic porcelain, but these materials are recommended in the restorative room. That is the part that is placed more coronal and is focused to get aesthetic integration. Remember, the biological room is focused to get the muco integration. So the hemidesmosome adherence to the crown, to the abutment. In the restorative room, we have another target. The target is to get the aesthetic integration.
This is part of that too.
Yeah,
I'll put
exactly.
that
And
up.
it's really interesting to see how in the animal study that we did, we were able to evaluate how the highest concentration of hemidesmosome were mainly located in the apical portion of the junctional epithelium. So exactly in the border between connective tissue and junctional epithelium. So it means that the connective tissue and the apical portion of the junctional epithelium that totally considered about a couple of millimeters is really the premium area of our emergence profile. Is the area where we can get the MOOC integration, so the soft tissue stability. Then what happens on the coronal aspect, it's important. In that coronal aspect, the dirty hands of the dental technician can work getting the aesthetics, but the two compartments are really different.
Yeah, so that I'm just going to have you summarize real quick. When I was training, they said you need biologic width 3 millimeters. And then you went on to say that, yeah, people were, for a lot of times, are still doing 3 millimeters from the buccal portion of the free gingival margin. But you're saying that's probably still not enough vertical space for the implant placement. You need 4 to 5 millimeters because of the hemidesmosomal attachment, or
the point is that this total running room that we have, of course, we don't have papers at the moment that describe how exactly how much is the space, the vertical height of the biological width. We have a nice paper from Gothenburg University from Cristiano Tomasi that evaluates the height of the biological width on implants, and he has evaluated how is really variable, but the mean value evaluated on all the samples was 3.6.
right.
So if the mean is 3.6, why I have to stay with 3?
That makes
When
sense.
I place an implant in the mouth, I cannot detect 3.5, 3.4, 3.2. No, it's impossible.
No.
I can detect 3, 4, and when I'm really in good mood, 3.5. So, I mean, if the mean is 3.6, I prefer to stay 4.
Yeah.
In order to be safe,
got to round
right?
up. You got to round up.
But
that's fine.
You know, the problem is that in implant dentistry, in my opinion, we have really many false friends. First of all, 3 millimeters. 3 millimeters, why? Because it was took from perio. It was took from what it works for teeth should work also for implants. Think also, for example, to the emergent profile, to how to design the crown. Why 15, 20 years ago, we used to go with this really bulky emergence profile, robust, no? Because we thought that biomechanically was better, but in particular because we thought that it was more similar to a tooth. And so we believed that it was much better. But today we know how the emergence profile have to flare out gently. And our restorations today are more similar to mushrooms instead of teeth. But it works like this because in the coronal aspect of the implant, in the biological room, we don't need morphology that flares out too much and too fast. So it's important to understand this because sometimes in my opinion, we want to make the mistake to think that what works for teeth, it works also for implant. It's not completely true because a tooth in the molar area has 3 roots, no, in the upper, 2 roots in the lower.
Yes.
You place the implant in the molar area. You can also place an implant with 6 millimeter of diameter. It's still a mushrooms, a big one, but it's still a mushrooms. So we cannot think that it's really similar.
No, yeah. So that's all. What I took away from some of that, like if you're going to error placing your vertical position, it's generally better to go a little deeper than you think, because I think that gives the restorative person, whether that be you or someone else, a little bit more room.
Yeah.
And it also helps with the attachments, separating those two zones better. And you had mentioned briefly, and we'll get to this, I know, let's just say you're doing an immediate implant. And because you're doing an immediate, you have to place it deeper to get that primary stability. And now let's say you're 6, 7 millimeters deep. I know now there's implant systems that have fixes for that. Let's say you're doing it with like one of the Nobel implants, that they have an N1 now, where they have a unique way to fix that. I know maybe other systems have it too, I don't know. But how do you fix that? Or how do you plan for that?
You mean achieving the primary stability or the management of the vertical position of the deep?
So let's say you're planning a case on an upper incisor, and you're going to take that tooth out and you want to try to do this as an immediate implant case. And you look on your cone beam and your prosthodontic planning where the crown needs to be, and you realize, hey, I have to put this implant in maybe 6, 7 millimeters deeper than that buccal free margin to make this work. So are you using conventional implants in those cases, or from the jump, are you saying, hey, I have a way to fix this from the initial surgery?
Okay, I got your point. Yeah, absolutely. I think that today, in this kind of scenario, it's absolutely recommended, and really I love to work with the intermediate final abutment. So, I mean, I place the implant in the right position, the position that is good for the emergence profile, for the primary stability, and all the tools, the aspect that I need. And then I place immediately during the surgery final intermediate abutment that I can identify before the surgery, because I have multiple options in height of this abutment.
Okay.
So I can choose the 1.75, the 2.5, the 3.5. I place it immediately on the top of the implant. I screw it at 20 Newton on the N1 implant system. And so what's happens that I'm creating a sort of customized tissue level concept. So I plan place my implants in the right position. Maybe I use a bone meal to prepare also the sites for the abutment. That is another important thing underestimated, because we cannot place an abutment deep in touch with the bone. Also, the site of the abutment has to be prepared. So I place this abutment, and in that way, I can reduce the distance from my free gingival margin and my prosthetic platform. And on the final intermediate abutment, it is completely sterilized. And normally, today, with the Xeal abutment, we have a boosted surfaces with the good chemistry, with the amazing hydrophilic properties. And so in that way, we can reinforce the muco integration and the midesmosome adherence that we can have in this area. So biological room is fixed, is managed, and then of course we work prosthetically only in the restorative room that starts from the base level. So absolutely, you touch really a good point. When I have to manage an aesthetic case today, my first option, my Formula One, is one. For the emergence profile configuration for the N1, so the possibility to work with one abutment one time with a final intermediate abutment that really fit really well in the aesthetic area. And in particular also because on the base level, I can produce a full zirconia crown, screw retained, without any T-base, without any need to cement the crown on the T-base. Because honestly, I don't like T-base. Yeah. And when I can work directly screw retained at the base level, I love.
So that's something I took away when I saw your lecture. I'm like, I wasn't even thinking about that, because most people use conventional, and I say conventional meaning there's implants that are bone level. And then they're placing generally some sort of healing cap or custom healing abutment, whatever they want to use. And my cat's going to start jumping on me here.
So cute.
So most people place a conventional implant, and then they place a healing cap or a custom healing abutment or something on it. And then let's just say if they plan from the jump, they know on their CT planning and their prosthetic planning that they're going to have to do an immediate, in this case, we're going to have to place this implant fairly deep to make it work. From the beginning, they can use a system, I guess, that can fix that. So what you're doing is you're placing, I guess, the N1 implant. And when you place that, say 7 millimeters deep to the free gingival buccal margin. Okay, that's deep, right?
It's deep.
What you're doing then is you're picking from your final abutments, essentially, in a way. I forget the name of them. What are they called again?
It's N1 base.
The N1 base. Okay, so there's an N1 base attachment that you actually torque on top of that implant to extend the implant height. And that stays on. You never take that off again. So what you've done is you've placed an implant 7 millimeters deep to the free gingival margin on the buccal. Let's say you put a 3 millimeter, one base on that, and you torque that into 20 Newton centimeters. Now your implant went from a 10 to like a 13 length. And now you can put your healing cap as normal, right?
Yeah.
So you basically, what you're doing is you're planning for that deep implant, and you're picking a set of, N1 bases to torque onto that to extend the height of your implant after the implant is actually placed. And now you're back to conventional implants. Essentially, you basically put your normal healing cap or whatever you like to do on that. So you fix that from the beginning without a grafting case, more, let's graft and come back. And then when you do that, you lose some tissue attachment on the adjacent mesial and distal of the other teeth. Like there's also, there's benefits and things to immediate placement, and you lose some of that when you graft and come back. Right?
Yeah, absolutely. But even when I graft, when I work with GBR or any kind of bone graft procedures, for sure, when I connect the implant in the intraoral environment at the reentry, always I use the and one base or a final intermediate component, because I want really to maintain the bone interface untouched, preserved. So I don't want to work with disconnection at the bone levels, in particular if I work with the regenerated bone.
Yeah, it's different quality right off the, like surgical quality is
Yeah.
different. So what happens when you take a healing cap on and off a bunch of times? So when I place an implant, I generally like to Ostel or ISQ check them in about 8 weeks or so or out. And I make sure that I like to make sure that the implant is stable enough for the dentist or restorative person to put a crown on it. So I have to take that healing cap off at least one time to do that. Okay. Just from my end to ISQ check it. And what happens if the dentist is taking that cap off multiple times before they get the final on? Like, what happens biologically with that? Why is that so bad?
Yeah, I mean, we are doing many papers on this topic, and recently we had also really good publications that really recently are released on a Medline and a PubMed. The point is that multiple disconnections on bone level implants cause contamination, irritation, and these disruptions, contamination, can cause an apical migration of the connective tissue and of the junctional epithelium, of course, also. So what does it mean? It means that there is an apical migration of connective tissue and junctional epithelium, and of course, this can cause bone remodeling. I want to invite you to make this kind of evaluation. Look the quality, the color, and the configurations of your soft tissue in the running room when you remove the healing abutment the first time after the surgery. Really often you see really an active area. You can see red color. Yeah, you can see something really red. You can see also a little bit some bleeding. And you know, the crazy thing is that people think that is inflammation. It's not inflammation. You have bleeding because on that abutment, placing one abutment one time, we had an hemidesmosome adherence. And when you go to remove it, maybe you disrupt it. And this is why it bleeds. If you, in the same patient, look to the configuration of the soft tissue after 4, 5, 6 disconnections, you can see that change completely. The red area disappear a little bit. The white deepest area that is the connective tissue disappear completely. And you can see that you have more pink, more epithelium that occupy the space of the running room. Why? Because the deepest area where we have the connective tissue and of course the deepest area of the epithelium, the junctional epithelium, migrates apically, causing bone loss. You know, during my lectures, sometimes I put 2 pictures in the screen, really big one. 2 different running rooms. One completely pink, and they call it Peppa Pig. Completely pink, without any bleeding, nothing. And the other one, like the picture that you show, with the really red color and so. And I asked the audience which one is better. And you know, always there is 50-50. And normally people doesn't like the red one because they think that red is inflammation.
Right.
Because we used to think that around teeth, when we have some bleeding, it means that it's inflamed. So we don't like the red. But in implants, it's different. When there is the red, it's because we had an adherence that unfortunately we disrupt. And if you disrupt multiple times, you cannot achieve the same adherence. We are conducting papers about this, looking to the soft tissue adherence on the Xeal abutment that we can have if the abutment is placed one abutment one time, or if the abutment is placed after 10 weeks, after 2 disconnections. And we have really a significant difference in terms of soft tissue adherence on the 2 abutments. So it means that the soft tissue adherence that we can get if the abutment is placed during the surgery when the healing process is really active, of course, is much stronger and better.
That's a lot to think about. I mean, we went through a lot in that little 5-10 minute thing. If you place an implant too deep and you plan it that way, there's a fix for that. You can use a system now, like the N1 or something, that you can place your implant deep, torque in a permanent base on top of that, and extend the length of that implant. Now you have a conventional way to restore that with what you normally do. You plan it from the beginning that way, and then you can account for that placement. You know, you place it where it needs to be, and that's where it is. That's where it's going to be primary stable, and then you can fix that vertical difference that way, which is awesome. The other part of that. Yeah, go ahead.
Sorry, I want just to point out that placing an implant really deep, like you mentioned, it's something that it is possible if necessary, right. But of course you need implants with a really tight connection. You really need an implant with a wedging effect between the implant and the connection that should be really high. is like to have one piece once that you torque it.
Right.
You cannot do it with an external X, of course,
No.
because it means to bring the big contamination that you have with the flat-to-flat connection at the bone level. So it's a nightmare. So this is the point. The new connections, the new implant design give us the chance to work differently.
Right. No, yeah, it's smarter because, for years, and people still swear by tissue level implants for being kinder to the tissue, right? You have that smooth surface on top that contacts the tissue and it's more natural, and the gums like that better. Now, like the Nobel TiUltras and things, they have that smooth anodized surface. It's a bone level implant, but it has that smooth surface on top also, which is probably kinder to the tissue, I would imagine, if it gets exposed over time, right? Than the roughened surface of most bone level implants, So that's also
the concept of these surfaces is that the gold area is a surfaces that can be also integrated, but it can be also MOOC integrated, or better, can be better MOOC integrated in case of exposure, because exposure, of course, can happen.
Yeah. Oh, yeah.
Maybe also if you look in a long-term perspective, after 10, 15 years.
Yeah.
So I think that is a good parachute. I like to consider it like a parachute. It can be also integrated, but if you have, unfortunately, some remodeling, you expose something that can be maintained much, much better.
Yeah, those patient-related factors in that puzzle piece is, age, physical biology,
Exactly.
Smoking, whatever they're doing, it's going to happen. You're never really going to grow more bone as you get older. In a lot of cases, it's always going to be less and less, and that makes sense that way. So yeah, and that N1 system, I know it's a completely different way to place implants. It's like one drill, maybe two drills to place the implant. That's pretty simple, and you don't even irrigate when you place it. I've done a few of these cases myself. I know you've done a ton of them. But how is that even different than, what are we talking about? What is that? How does that system work?
Yeah, it works that you have a first drill that it works in high speed with irrigation that is called Osseointegration. And it's really important to use correctly this drill for the placement of the implant, because it's crucial to use correctly this drill. And my recommendation, when it's possible, is always to over-prepare the site a little bit with Osseointegration. Okay. If you can go deeper with your preparation, let's go, because it helps for the Ossoshaper. The Ossoshaper is a second drill. It works in a low speed without irrigation, and it works at about 50 RPM with a maximum torque of 40 Newton. And the good aspect of this specific new tool is that Ossoshaper can cut the bone if the bone is hard, and at the same time can compact the bone if the bone is soft. So it means that you have the possibility to place the implant always in the same bone quality, because it's like that the Ossoshaper can prepare the bone in the ideal situation in order to place your implants. We have two different Ossoshaper. One is the regular one that is normally used in the 80% of the situation, but sometimes we need also an Ossoshaper 2 that is a little bit more aggressive. It still works in a low speed without irrigation, and is needed when the bone is really hard, or maybe when you work between two corticals. And so, of course, your Ossoshaper is engaging two corticals, and so is needed something more aggressive.
Okay. So if you're thinking conventional implants, if you're placing an implant in, very dense bone, a lot of times a lot of systems have a tap, right? So you go to a tap, and then you take that out, and then you irrigate and place your implant. So if in most cases for these N1s, you're using the Osseoshaper and then Osseodirectors, right? If you feel that bone is really dense, you might want to go to the next level, Osseo-shaper.
Yeah, Osseo-shaper 2.
Yeah, 2.
Osseo-shaper 2.
But you're probably doing that maybe 15-20% of the time. You're going to the 2 in a lot of cases. Probably.
Yeah, it's not really. Of course, if you manage all the day, all on 4 in the lower jaw, and you place the implant in really intraforaminal bone, maybe it's not at 15-20%, but could be also 30-35%. Right. It depends on what is your daily routine. But in my experience, in the 80-85%, I use just Osseo-shaper 1. And it's really interesting to see also the feedback from the patient, because when we use a traditional approach with high speed and irrigation, for the patient is not something really comfortable, because they feel a lot of noise, and of course they have all the water in the mouth. That is not comfortable, right? When you go with Osseo-shaper, with the no vibration, no water, it's really comfortable for the patient, and the patient are super happy about this. It's a different experience.
Are you liking the N1 for immediate cases then? Because you can control that implant height because you have option to extend that if you wanted to, or does it matter?
Yeah. I love to use N1 for immediate implant placement. It's probably one of the best indications in my opinion.
How is it
In the
different
aesthetic area
restoring?
for sure.
How is it different restoring that N1 versus like a normal implant? Like you have to use different components then?
Yeah. You have completely different prosthetic portfolio. I can tell you that in terms of prosthetic design is much, much better, biologically speaking. But considering that the prosthetic components are really small, the screws is also really small. So what does it mean? That the handling is a little bit tricky.
Right.
In particular in the beginning. Or in particular, if you work in the molar area, working with these really small and short screws sometimes can be a little bit not comfortable like to work with the traditional implants.
Use your
But
loops.
if you manage it in the static area, this problem is not really a big issue because of course you can see better, you can manage everything in details. Yeah. But I think that they are fixing it. I think that they are working on it. You know, consider that the screw of the diameter of the clinical screw, it's about 1.5. A traditional implant has a screw diameter that is about 2.2.
Right.
And this is the reason why the emergence profile is really slim, because the screw is slim, because otherwise you cannot get a slimmer emergence profile if you still have a super wide screw.
Yeah. I mean, if anyone's, doing full arch cases and you're using a multi-unit abutments, those screws are also very tiny. So you're kind of used to working with these little fleas that are jumping around sometimes.
Exactly.
Get used to that. Yeah, so that's a cool way to plan these cases, and it's a completely different way of thinking in implant dentistry, which I came out of that going, "Whoa, that's cool! I didn't even know you could do that." I could plan for I really need a 15, but I don't want to place it that deep. There's ways to plan for that, which is cool. I'm looking at your puzzle piece here, and just before we end here, I'm trying to see if we missed anything. If you can think of anything. Let's see. Oh, I was going to say, so the little thing I got from your talk also was implant diameter. Like there's a whole, so in the US for many years, there's a way of thinking, like if you're placing a 19, like a molar implant on the bottom, lower jaw, you need like a 6 or millimeter diameter or 5. You need some wide diameter implant. Is that your level of thinking there? What are people, I know in different areas that's a whole different topic. Like the diameter of your implant, does it matter that much if you're doing a molar versus a premolar? Does it make that big of a deal? Like if you can only get a 3.5 or a 4 millimeter diameter in for a molar, is that okay? Like, I'm just curious.
Yeah, we have to make a distinction between the diameter of the implants and the diameter of the connection, because today we have also wider implants with the same connection. And I think that is really important, this aspect. First of all, I like to place a 5 millimeter implant in the molar area when I have enough bone. But at the same time, I always like to work with the regular platform connection. When you have a conical connection implant and you use a 5 or even 6 millimeter diameter implants, and you're still working an RP connection, regular platform, what does it mean? It means that you are increasing a lot as mismatch between diameter of the implant and diameter of the abutment. So you are increasing the plasma switching. And when you increase the plasma switching, of course, you can get the ideal biological result. There is a nice paper by Canullo that explains how with the bigger mismatch, you have less bone remodeling. So it's really important to work in this direction, because remember, the plasma switching is an horizontal distance between the bone and your microgap and your connection. So it's like a tissue level, but moved of 90 degrees. It's an horizontal distance. So if you can get it longer, bigger, is much better. So in the molar area today, my first option is to work with the 5 millimeter implants with a regular platform connection. I don't use wide platform.
Yeah, that was the way of thinking for a long time. Like the wider the better back there, blah, 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 blah. But you don't need to go that wide in a lot of cases to make it work.
Yeah,
but
absolutely.
Yeah. So how can people find you if they want to have questions? And honestly, if people watching have more questions on what we talked about, let us know in the comments and things, and hopefully we can get back to you and answer those.
Absolutely. They can follow me in my Instagram account, and it will be great if we can tag also you, and we can have absolutely a nice conversation between you, me, and of course all the participants. It's Dr.Giacomo Fabbri. This is my Instagram account, and absolutely I'm open to answer to any kind of question absolutely around this topic.
Yeah, I feel like we can talk about this stuff. There's way more than this stuff, honestly, that you talk about. But we can go on for hours and hours. But we gotta end it somewhere. I know it's a Friday night over there. You gotta get out. You gotta change. Get in your Formula One, and get out.
But I'm really enthusiastic about this kind of moment of implant dentistry, because really moving the tension from the bone to the soft tissue, it is opening many scenarios. For example, right now we are looking on how the material of the abutment can influence the microbiome and the microbiota of the sulcus of the implant. So it means that maybe with the abutment material, we can influence the health of the soft tissue, because we can get the surfaces with an active properties that can influence also these aspects. So look how many projects we can looking forward in the next years.
It's crazy. I was looking at even papers and things like nanotechnology releasing microdoses of antibiotics through your restorations. Like there's some cool stuff that people are trying out and figuring out how to do. That's awesome. And I even have questions on zirconia versus, anyways, we can maybe for a future topic, but I want to thank you again, my man, for coming out. I know it's taken up one of your prime weekend nights here. I really appreciate it. And thanks for coming on.
Thank you. It was my pleasure. And thank you for inviting me. A great privilege to have the chance to spend this hour with you, and really looking forward for the next. Yeah, absolutely. Thank you.
Thank you.